One of the most effective treatments for heart failure is Burinex, a favorite choice among cardiologists and patients for years. It is a popular loop diuretic known for its reliability and positive outcomes. The significant value of Burinex lies in its ability to overcome diuretic resistance effectively. So what's diuretic resistance? After a period of loop diuretic usage, there is a decline in the effectiveness of loop diuretics, leading to recurrent episodes of decompensated heart failure. That's mean, as time passes, diuretic resistance emerges. Loop diuretics take a long journey, starting from absorption and ending at their site of action. In heart failure patients, several obstacles can impede it to reach its site of action, leading to diuretic therapy failure known as diuretic resistance. Loop diuretics commence their journey in the small intestine, then utilizing albumin in the blood for transport. Eventually, they enter the renal tubule, where they reach their site of action in the kidney. This process involves 3 distinct steps for loop diuretics to reach the kidney or their site of action. In patients with heart failure, 3 challenges significantly impact the delivery of loop diuretics to their site of action: intestinal edema, secretory deficiency, hypoalbuminemia. Loop diuretics encounter 3 significant obstacles during their journey. First, they face challenges in the intestinal phase, especially if there's intestinal edema. Second, as they travel through the blood, hypoalbuminemia in heart failure patients can hinder their progress. Lastly, when they reach the kidney and need to be secreted into the renal tubule, further difficulties may arise. These obstacles collectively impede the smooth movement of loop diuretics to their site of action. Intestinal edema. Diuretic resistance can arise due to gut edema, obstructing drug absorption. In normal patients, the intestinal wall thickness remains normal, allowing for predicted drug bioavailability. However, in heart failure patients with gut edema, the intestinal wall thickness increases, impeding drug absorption. Hypoalbuminemia. Reduced albumin levels in many heart failure patients impact drug transportation. Loop diuretics rely heavily on the presence of protein albumin. In normal patients, there is a good concentration of albumin, which enables the expected amount of loop diuretic to be absorbed and transported to its site of action. Indeed, in cases of hypoalbuminemia, where there is a deficiency of albumin, less loop diuretic can be picked up and transported to its site of action. This condition can impact the effectiveness of loop diuretics in such patients. However, less protein-dependent transportation to the kidney ensures the efficacy of loop diuretics, even in cases of hypoalbuminemia. This guarantees that the drug reaches the renal tubules more effectively than those relying on higher levels of albumin. Entry to renal tubule. How does loop diuretics reach the site of action? At the point of entry into the kidney, when loop diuretics reach this organ, they require a specific pathway to access the renal tubule to reach their site of action. This process does not rely on filtration through the glomerulus, but instead utilizes the proximal convoluted tubule as its gateway. This entry process is receptor-dependent, hinging on a specific receptor known as the organic anion transporter, or OAT. Once it is secreted into the renal tubules, loop diuretics are transported by the urine flow to their site of action in the thick ascending loop of Henle when it prevents Na, K and Cl from being absorbed and enhances diuresis. How does tubular secretion reduced in HF and CRF? Patients with heart failure and chronic renal dysfunction have elevated levels of circulating organic acids, such as blood urea nitrogen, which competitively inhibit the organic anion transporter, OAT, and further reduce diuretic availability at the site of action. Types of loop diuretics. There are 3 main types of loop diuretics: furosemide, bumetanide, and torsemide. While they all belong to the same class of medications, they have differences in how they interact with obstacles in heart failure patients on their journey to reach their site of action in the kidneys. Intestinal edema. Firstly, Burinex's high bioavailability, up to 100%, allows it to easily bypass gut edema, unlike furosemide, 40%, which is impeded by edema. So, bioavailability of Burinex 100%. Hypoalbuminemia. Secondly, Burinex is less affected by hypoalbuminemia because it has lower protein binding, up to 94%, ensuring more free drug reaches tissues, unlike furosemide and torsemide, up to 99% binding. Burinex less albumin dependent, easily distributed to the kidney. So, Burinex less albumin dependent and can easily distribute to their site of action. Renal tubule entrance. Burinex's high lipophilicity enables it to pass through renal tubules without dependence on organic anion transporters, making it less affected by high levels of organic acids like high blood urea nitrogen, unlike torsemide and furosemide, which rely heavily on these transporters due to their lower lipophilicity. Burinex, owing to its high lipophilicity, possesses two pathways to reach the lumen of the tubule: transcellular and paracellular transport. On the other hand, torsemide and furosemide, being less lipophilic than Burinex, rely solely on transcellular transport, utilizing the only O-A-T transporter, and they lack the opportunity for paracellular transport. How do they differ to bypass diuretic resistance? Owing to its high lipid solubility, bumetanide is able to diffuse actively and passively to its site of action, unlike other loop diuretics, which require active tubular secretion. Easier passively and actively pass to renal tubule, that's mean Burinex has less competition with BUN and another anion. In conclusion, Burinex can overcome all three barriers: absorption, distribution, and entry into the kidney. On the other hand, furosemide faces challenges with all three barriers. As for torsemide, it can overcome absorption obstacles but has lower distribution and kidney entry capabilities compared to Burinex. This position Burinex is a solution to break barriers of diuretic resistance. Added to the three challenges previously mentioned, the significant challenge with loop diuretics in heart failure is the kidney's ability to compensate for reduced sodium absorption. This compensation occurs by increasing sodium absorption on the other side, a phenomenon known as the braking phenomenon. To address this issue, it is advantageous to have a loop diuretic with multiple sites of action. Such diuretics can block a broader range of areas within the renal tubules, helping to counteract the effects of hypertrophy and hyperplasia in neighboring regions. This strategy is essential in bypassing the braking phenomenon and maintaining the diuretic's efficacy over time. After extended use of loop diuretics, their primary site of action, the ascending part of the loop of Henle, becomes blocked, inhibiting sodium reabsorption effectively. However, as a compensatory response, other renal tubule segments may undergo hypertrophy, essentially overgrowing to compensate for this blockage. This hypertrophy and hyperplasia in adjacent areas can lead to increased sodium reabsorption, ultimately weakening the overall effectiveness of the loop diuretic. Burinex primarily blocks the ascending loop of Henle's function. However, it also has an additional blocking action on the proximal convoluted tubule. This secondary effect helps to counteract the compensatory mechanism that usually increases sodium reabsorption. Burinex has two sides of action. Burinex breaking all barriers of diuretic resistance. Burinex. Help your HF patient, treated with less diuretic resistance.